Welcome to the deep dive. Today, we're tackling a really significant health challenge, diabetic foot ulcers. We're going to be drawing on the extensive knowledge in Rutherford's vascular surgery and endovascular therapy, 10th edition.
Right, a key text.
Think of this as, your fast track to understanding what these ulcers are really all about, the underlying issues, what causes them, and the potential paths forward.
Yeah,
We're here to give you the crucial info without getting bogged down in, well, overly technical stuff.
exactly. Our aim is to pull out the really vital knowledge for you. We'll navigate the complexities to give you a clear, understandable overview of diabetic foot ulcers, focusing on what's most important to grasp.
Okay, let's start with some perspective. The global reach of diabetes is just enormous, and foot complications are a huge part of that picture.
They really are.
Back in 2020, over 463 million people worldwide were living with diabetes. And experts predict that number could climb to, 700 million by 2045?
It's a staggering projection, a massive issue globally.
It really is widespread. And on a more personal level, diabetes is a leading cause of foot problems. In fact, in the US and Canada, most non-traumatic amputations are a direct result of these diabetic foot ulcers. The sheer scale is the key insight here.
And when we look at the U.S. specifically, the individual risk is, well, pretty substantial. Up to 15% of people with diabetes might have an active foot ulcer at some point.
15%.
And maybe even more striking, 1 in 4 have a lifetime risk of developing one.
1 in 4.
Yeah. These aren't just minor things. They profoundly affect people's quality of life.
Absolutely. And the financial impact is huge too, isn't it?
Oh, definitely.
Complications from these ulcers are the #1 reason people with diabetes end up in the hospital.
That's right. Leading cause of hospitalization for this group.
And the costs are just, well, we're talking estimated treatment costs for just one ulcer,
Right.
ranging from maybe $8,000 to $17,000.
Yeah, and that's just for the ulcer itself, assuming things go relatively well.
Right. And if an amputation becomes necessary, that figure just skyrockets maybe $40,000 to $60,000.
Easily. It puts a tremendous strain on our healthcare system beyond the personal cost.
The stark financial reality really underscores why early prevention and effective management are so critical. It's not just for individual well-being, but for the whole system. It's an economic problem, too.
So, while this is clearly a serious situation, our aim today is to provide clarity and highlight the possibilities for effective management. We want to empower you with understanding, not overwhelm you.
Okay, let's unpack this complex issue then. Diabetic foot ulceration. It sounds like it's rarely just one single thing going wrong.
That's absolutely right. It's almost always a combination of factors creating the perfect storm, so to speak, for these ulcers to develop.
And while lots of things can play a role, what are the main culprits we should focus on?
Well, the primary risk factors, the big two, are diabetic peripheral neuropathy, that's nerve damage,
Okay.
and peripheral arterial disease, or PAD, which affects blood flow to the feet.
Right, PAD.
These two often work together, unfortunately, compounding the risk.
And it doesn't just stop there, does it? Our sources also point to other significant contributors.
Yeah, there's more to it.
Things like infections in the soft tissues, biomechanical problems like the actual structure or movement of the foot,
Foot shape,
Yeah.
joint movement.
swelling, edema, calluses, that thick skin buildup,
Yep.
kidney issues, maybe poor controlled blood sugar levels over time, age itself, and just how long someone has actually had diabetes. It's quite a list.
It is. And it's crucial to remember that sometimes even seemingly minor trauma can be the trigger, especially if someone has neuropathy and they just don't feel the initial injury.
Like what kind of minor trauma?
Oh, something as simple as shoes that don't quite fit right, rubbing in the wrong spot, or stepping on something small. Because of the neuropathy, it goes unnoticed until, bam, there's an ulcer.
Let's dive deeper into that neuropathy role then, because it sounds like a primary trigger. You mentioned somatic neuropathy that affects sense of touch. What makes it so dangerous? It's like a silent danger, isn't it?
It really is. And what's particularly insidious is how gradually it develops. Somatic neuropathy progresses slowly, often unnoticed at first, but it can eventually lead to a complete loss of protective sensation in the feet.
No feeling at all.
Essentially, yeah. And this lack of feeling dramatically increases the risk of injuries just going completely unperceived. Think about stepping on a sharp object barefoot, or getting a burn from hot pavement or bath water without realizing it.
Ouch.
Even just trimming toenails too short can become a significant starting point for trouble if you can't feel it.
Our sources emphasize that somatic neuropathy alone can increase the risk of foot ulcerations 7-fold.
sevenfold. That's a massive jump in risk just from the nerve damage. And it's not just about losing feeling, is it? Neuropathy also affects the mechanics of the foot itself. Precisely.
Yeah.
That's a really important point. Neuropathy can lead to muscle wasting, the small muscles in the foot weakening, and that creates imbalances.
Imbalances how?
Well, this weakening of the muscles, say in the calf and foot, can cause deformities. A common one is called an equinus deformity, where there's limited upward bend at the ankle.
Right.
These kinds of changes shift how pressure is distributed when you walk, often increasing the pressure right on the forefoot.
Ah, and you said the forefoot is the most common spot for these ulcers.
Exactly. For these neurotrophic ulcers, the ones primarily driven by nerve damage, the forefoot is the classic location because of that increased pressure.
And there's another type of neuropathy involved too, right? Autonomic neuropathy. How does that play in?
Yeah, autonomic neuropathy affects the body's automatic functions, things we don't consciously control. And it has some maybe surprising effects on the skin of the feet.
Like what?
Well, a key impact is on the sweat glands. Autonomic neuropathy reduces sweating.
Okay, so dry feet.
Very dry feet. The skin becomes fragile, less elastic, much more likely to crack or develop tiny tears, fissures.
And those cracks are openings for.
Exactly. Entry points for bacteria. Increases the risk of infection significantly. And furthermore, it can mess with the microvascular regulation, the control of the tiniest blood vessels in the skin. This can sometimes lead to a foot that looks warm, maybe even reddish, and well perfused.
So it looks healthy.
It can give a false impression that everything's okay, yeah. But in reality, the foot is insensitive and highly vulnerable. It's a misleading picture sometimes.
Okay, so neuropathy sets the stage with lack of feeling and foot changes.
Yeah.
Now let's switch gears to peripheral arterial disease, PAD. Our sources say it contributes to about half of all diabetic foot ulcers.
That's right. Around half have some significant PAD component, and it's also a major factor linked to mortality in diabetic patients, so it's very serious.
So we've seen how nerve damage creates vulnerability. Now, how does this poor blood flow, the PAD, compound that risk?
Well, connecting this to the bigger picture, PAD in folks with diabetes is a huge concern. The classic pattern you often see is what's called infrapopliteal occlusive disease.
Infrapopliteal, meaning?
Below the knee, blockages primarily in the arteries of the lower leg, the tibial and peroneal arteries. That's a key area.
Right.
And these blockages often have significant calcium buildup in the artery walls, making them hard and stiff. This is a bit different from, say, blockages in the femoral artery in the thigh, which seems to happen at similar rates whether you have diabetes or not.
Got it. Now, I remember hearing, maybe years ago, this idea that problems with the really tiny blood vessels in diabetics' microvascular disease meant that procedures to improve blood flow in the bigger arteries wouldn't work well. Is that still the thinking?
That's a really crucial point to clarify. That old idea, the sort of therapeutic nihilism about microvascular disease preventing successful revascularization, it's largely been disproven.
Good.
While diabetes does affect the basement membrane of the capillaries, the tiniest vessels, it doesn't automatically mean you can't benefit from fixing the larger arteries feeding the foot. Improving that inflow is still critical.
So revascularization can still work.
Absolutely. Though interestingly, diabetic patients do have an increased risk of disease, specifically in the digital arteries, the very small vessels going to the toes themselves.
Even if you can feel pulses further up the foot.
Yeah, exactly. You might have palpable pedal pulses, but still have significant blockage in those tiny toe arteries, which can definitely lead to ulcers or poor healing right at the tip of the toe.
So what about treating PID in those lower leg arteries, the tibial arteries, in diabetic patients? Is that something that could be done effectively?
Oh, absolutely. It's often challenging technically because the vessels are smaller and can be heavily calcified, as we mentioned, but tibial revascularization is very often possible.
And important.
And incredibly important, especially targeting the specific artery that supplies the area of the ulcer, what we call the angiosome.
The angiosome. Like a territory.
Kind of like a vascular territory, yeah. Restoring direct flow to the angiosome where the ulcer is located is crucial for overcoming that ischemia, the lack of blood flow, and really promoting wound healing. It significantly improves the chances.
Okay, that makes sense. Now, another big concern you mentioned is infection. About half of these ulcers get infected.
Roughly half, yes. And once infection sets in, it dramatically increases the risk of needing an amputation. It's a major turning point.
So how do doctors figure out how bad an infection is? Is there a system?
Yeah, this brings up how clinicians approach it. The PEDIS classification system is a really valuable tool here.
PEDIS. What's that stand for?
It stands for perfusion, extent, size depth, tissue involvement, infection, and sensation. It helps categorize the severity, particularly the infection component, and guides treatment decisions.
Okay. So if an ulcer looks infected, maybe it's red or there's pus, is it standard practice to take a wound culture to see what bacteria are involved?
Generally, yes, if there are clear signs of infection. Pus draining, redness spreading out from the wound, cellulitis, maybe a bad odor, or the tissue breaking down further. In those cases, a culture is definitely warranted.
But not always.
Right. If an ulcer appears clean, maybe just granulating nicely, and there are no signs of local infection or the patient doesn't seem systemically unwell, then routine swabbing isn't usually recommended.
Why not?
Because a swab in that case is likely just going to pick up colonizing bacteria, the normal stuff living on the skin which aren't necessarily causing the problem.
And that could lead to
Unnecessary antibiotic use, potentially contributing to resistance. So, we culture when we suspect infection is actively hindering healing or causing problems.
Okay. So if a culture is needed, is there a best way to get the sample? Just swab the surface.
Good question. What's interesting here is the quality of the sample really matters. When a soft tissue culture is needed, samples taken during surgery or by carefully scraping the base of the debrided wound, a technique called curettage, are much better.
Better than a swab.
Much more accurate in identifying the actual bacteria causing the infection compared to just swabbing the surface drainage. This helps target antibiotic therapy much more effectively.
Makes sense.
And another complicating factor for diabetics is that they often have an impaired ability to even get the antibiotics to the infection site effectively.
Why is that?
It's related to elevated levels of certain adhesion molecules in their blood, which can affect how blood vessels function and ultimately reduce blood flow, the perfusion, right down to the skin level, so delivery can be hampered.
Wow, another challenge. Okay, let's shift to the role of muscles and bones. Our sources mention deformities and limited joint movement creating pressure points. Can you expand on that?
Certainly. Diabetic bony deformities, think common things like bunions, which is technically hallux valgus,
Right.
or claw toes, where the toes are kind of contracted upwards, and problems with the joints where the toes meet the foot, the MTP joints. These, along with just stiffness or limited movement in the joints, can really change how weight is distributed across the bottom of the foot.
Creating hot spots.
Exactly, areas of abnormally high pressure. And these pressure points are prime locations for ulcers to develop. And tying back to neuropathy, the lack of sensation means these can form and worsen without the person even realizing it.
And how does muscle weakness fit into this? Does that cause problems too?
Yes, absolutely. Muscle weakness, particularly in the small intrinsic muscles within the foot itself again, often due to neuropathy, leads to imbalances between the tendons that control the toes.
Imbalances leading to
Deformities like hammer toes, where the toe joints buckle. This makes the tops of the knuckles vulnerable to rubbing against shoes.
causing ulcers on top of the toes.
Yep. And the contracted toes can also push down more forcefully on the heads of the metatarsal bones on the sole of the foot, increasing pressure there too. It's all interconnected.
Our sources also mention something called Charcot foot. That sounds serious. What is that, and how does it relate to ulcers?
Charcot foot, or neuroosteoarthropathy, is a really significant complication. It's basically a condition where, due to neuropathy, the bones in the foot and ankle can weaken, fracture, and dislocate, often with minimal or no recalled trauma.
The bones just break down.
Essentially, yes. It's an inflammatory process triggered by neuropathy. If it's not caught and treated early with strict immobilization and offloading, keeping weight off it completely,
What happens?
it can lead to a severe collapse of the arch, often in the midfoot, resulting in a characteristic rocker bottom foot deformity.
Rocker bottom.
Yeah, the arch collapses, and the bottom of the foot becomes convex, like the bottom of a rocking chair. This abnormal shape creates areas of incredibly high pressure on the sole, making it extremely prone to ulceration and very difficult to heal.
Wow.
And it's not just Charcot. Other mobility issues like flat foot deformities, stiffness in the ankle, even problems higher up like knee or back issues that change how someone walks can all add to the biomechanical stress on the foot and contribute to ulcer risk.
Okay, so with all these potential factors, nerves, blood flow, infection, bone structure, mechanics, how do doctors actually go about diagnosing and assessing a diabetic foot ulcer when a patient comes in? What information is key?
A really thorough evaluation is absolutely crucial. It always starts with a detailed patient history.
What kind of things are you asking about?
Well, you need to know about their diabetes management. How's their sugar control? What medications are they on? When did the ulcers start? Was there any specific event like a new pair of shoes, an injury, recent travel? How long has the wound actually been there? Has it changed in appearance?
Review these problems too.
Definitely. Any history of previous ulcers or foot surgeries? What treatments have they tried? And critically, you need to ask about any systemic symptoms that might suggest a deeper infection, feeling generally unwell, fever, chills.
Got it.
And also look for those underlying risk factors we've discussed. History of diagnosed neuropathy, any symptoms of PAD like leg pain when walking, existing foot deformities they know about, any past vascular procedures.
And then the physical exam. What does that involve?
The physical exam has to be comprehensive. You're looking at the skin, the nerves, the blood vessels, and the musculoskeletal system, the muscles and bones.
Okay, starting with the skin.
Yeah, check the skin for dryness, brittleness, any cracks. Look carefully for areas of thickened skin, that hyperkeratosis or callus, which often indicates pressure points and can hide an underlying ulcer or pre-ulcerative changes.
Like what kind of changes?
Little pinpoint hemorrhages under the skin, sometimes called Herald spots. You should feel calluses carefully. Is there any fluid, like a blister, underneath? Any suspicious thickened skin needs to be carefully trimmed away, debrided, to see what's really going on beneath it.
Makes sense. What about the nerve and vessel checks?
For the nerves, sensory testing using a Semmes-Weinstein monofilament is key. It's a simple nylon fiber. Losing the ability to feel that filament touch the foot in several standard spots indicates loss of protective sensation and high risk. For vascular, you palpate feel for pulses in the legs and feet. But, and this is important in diabetics, pulses can sometimes feel normal even if there's significant PAD because of that vessel calcification we talked about.
Right, the stiffness.
Exactly. So pulses alone aren't enough. You usually need non-invasive vascular testing, like the ankle brachial index, the ABI.
But you said the ABI can also be unreliable.
It can be, yeah. Calcification can make the arteries incompressible, giving a falsely high ABI reading. So you often need other tests too, like toe pressures or waveform analysis.
Okay, and musculoskeletal.
Check for any obvious deformities, bunions, hammer toes, that sort of thing. Look for signs of motor neuropathy, like wasting of the small muscles in the foot. And specifically look for signs of Charcot foot. Is the foot warm, swollen, red compared to the other side? Is there that rocker bottom deformity? You also check the range of motion in the ankle and the big toe joint. Stiffness there can really impact walking mechanics.
So once you've found an ulcer, how do you evaluate the ulcer itself? And how are they classified?
You inspect the ulcer very carefully. What does the base look like? Is there healthy pink granulation tissue? Or is it pale, yellow, black? Is there drainage? What kind? Is there pus? Any odor? Redness spreading around the edges?
Documenting everything.
Exactly. Note the size, length, width, depth. Note the precise location. How many ulcers are there? Then, a sterile probe, like a blunt metal instrument, is gently used to feel inside the wound.
What are you probing for?
To check the depth, see if there are any hidden tunnels or pockets extending from the main wound, and crucially, to feel if the probe touches bone.
And if it touches bone.
If you can feel bone at the base of the ulcer with the probe, that raises a very high suspicion for osteomyelitis bone infection. It's a classic clinical sign.
Okay, and the classification systems.
Yeah, several systems exist to help describe and stage the ulcer. The Wagner system is an older one, still used sometimes. The University of Texas UT system is also common. We remembered the PEDAS system earlier. More recently, the WIFI classification, that's wound, ischemia, and foot infection, has gained a lot of traction. It's been well validated and is quite comprehensive in assessing severity and predicting outcomes.
WIAI.
Yeah.
Okay. And what about imaging tests? When do X-rays or other scans come in?
Radiologic investigations are often very helpful. Simple X-rays of the foot are usually the first step. They can show underlying bony deformities, maybe some signs of bone destruction from infection, and sometimes even gas in the soft tissues, which indicates a severe infection.
And if the X-ray isn't clear or you need more detail?
If an ulcer just isn't healing despite good care, or if you strongly suspect osteomyelitis or a deep abscess, then more advanced imaging is usually needed. That could be a CT scan, an MRI, or nuclear medicine scans like a bone scan or a white blood cell scan.
Which one is preferred?
Well, PE scans and labeled white cell scans are probably the most accurate for detecting bone infection, but they aren't always readily available. MRI is often considered the preferred first-line advanced imaging study for working up suspected osteomyelitis because it gives great detail of both bone and soft tissue, has good sensitivity, and is generally more accessible.
Okay, that gives us a good picture of diagnosis. Now let's move into management strategies. What are the sort of general principles guiding treatment? Outpatient versus hospital.
Right. The first big decision point is often whether the patient needs to be admitted or if they can be managed as an outpatient. If there are clear signs of severe systemic infection like sepsis, high fever, confusion, or rapidly spreading infection in the foot, then urgent hospital admission and likely surgical intervention are absolutely necessary.
But many can be managed outpatient.
Yes, many patients with more stable, chronic ulcers without severe infection can be managed effectively in an outpatient setting. This typically involves regular visits to a specialized wound clinic.
And what happens there?
Outpatient care focuses on several key things. Local wound care is central cleaning, debridement, dressings, arranging any necessary diagnostic tests we talked about, like imaging or vascular studies, getting specialist consultations if needed, vascular surgeon, podiatrist, infectious disease specialist.
Dressing changes and...
Debridement, yeah. Regular visits for those are common. There are tons of different wound dressings available, foams, gels, alginates, silver-impregnated ones, and the choice depends on the specific wound characteristics, like how much drainage there is.
And antibiotics if infected.
Absolutely. If infection is present, culture-directed antibiotics are a key part of the treatment plan, whether oral or sometimes IV initially. The ideal overall approach aims to control infection and inflammation, maintain a moist wound environment which promotes healing, and critically provide pressure relief.
Debridement, removing damaged tissue, keeps coming up. Why is that single step so important?
Debridement is absolutely fundamental. You could argue it's one of the most important interventions. Its purpose is to create a wound environment that's actually conducive to healing.
How does it do that?
By removing all the unhealthy stuff that thickened hyperkeratotic skin around the edge, any dead or necrotic tissue, foreign debris, and importantly, reducing the bacterial load in the wound. By getting rid of that non-viable tissue, you essentially reset the wound bed, stimulate the release of growth factors, and disrupt bacterial biofilms that can prevent healing.
Are there different ways to debride?
Oh yeah, several methods. Sharp debridement using a scalpel or curette is very common. Surgical debridement might be done in an operating room for larger or deeper wounds. There are also enzymatic ointments that help dissolve dead tissue, dressings that promote autolytic debridement using the body's own enzymes, mechanical methods like irrigation, and even specialized tools using ultrasound or pressurized fluid like hydrosurgery.
Is it painful, given the neuropathy?
That's a good point. Because many patients have significant neuropathy, aggressive debridement can often be done right in the clinic with minimal or even no discomfort. However, if the patient is anxious, or if a very extensive debridement is needed, local anesthesia or conscious sedation, maybe even requiring the OR, might be necessary.
And it might need to be done more than once.
Oh, frequently. For larger wounds, repeated debridements are often needed every few days or weekly until you achieve a healthy, clean wound bed composed of bleeding granulation tissue.
And if bone is exposed?
If bone is exposed in the base of the wound, it needs to be debrided aggressively, scraped or turned back until you see healthy, stippled, bleeding bone. And crucially, samples of that bone should be sent for culture to check for osteomyelitis.
Okay, and after debridement between visits, what kind of local wound care happens?
Between the debridements, the wound is typically covered with moist dressings. Sometimes dressings containing silver are used for their antimicrobial properties or specialized creams. Another important modality is negative pressure wound therapy, or NPWT.
The wound VAC.
Exactly. The wound VAC is a common brand name. Studies have generally shown that NPWT can be more effective than just standard moist dressings in promoting granulation tissue, shrinking the wound size, and achieving closure, often in a shorter time frame.
Got it. Now, our sources really hammer home the importance of offloading. What exactly does that mean, and why is it so critical?
Offloading basically means taking the pressure off the ulcerated area of the foot. And it is absolutely essential. You simply cannot heal a pressure-related ulcer if you keep putting pressure on it. Continued pressure prevents healing and can even cause new ulcers.
Makes sense.
The more effective the offloading method is, and crucially, the better the patient adheres to using it, the higher the likelihood of healing. It's often a major challenge.
What kinds of methods are used?
Various methods. It can range from specialized therapeutic shoes with custom inserts that redistribute pressure, to removable braces or walker boots, all the way to total contact casting. or TCC.
Total contact casting, like a plaster cast.
Pretty much, yeah. It's a specially molded cast that encases the foot and lower leg, designed to distribute weight very evenly over the entire sole and lower leg, taking pressure off the specific ulcer site. Studies consistently show that TCC and similar irremovable cast walkers are the most effective methods for healing neuropathic foot ulcers.
More effective than removable boots.
Generally, yes, largely because patients can't easily take them off, ensuring consistent offloading. Referral to an orthotist, a specialist in braces and supports, is highly recommended for fitting custom footwear, orthotics, and braces, as these often need careful monitoring and adjustment over time.
Patient education seems like another cornerstone here. What do patients and their families really need to know?
Absolutely vital. Given that these ulcers can develop silently due to neuropathy and lead to such serious complications, educating patients and their families is paramount.
About what specifically?
Understanding their personal risk factors, knowing how to inspect their own feet daily, recognizing early warning signs like new redness, swelling, drainage, warmth, or any break in the skin, and knowing when to seek immediate medical attention, not waiting thinking it might get better on its own.
And prevention.
Yes, education on preventive foot care, proper nail trimming, appropriate footwear, avoiding going barefoot, managing blood sugar is crucial. Regular foot inspections by healthcare providers are also part of this.
We've talked about standard wound care. What about some of the more advanced or newer treatment options, like skin grafts?
Yeah, there's a whole growing field of advanced wound therapies. This includes bioengineered skin substitutes, various types of cell-based grafts, and things like amniotic membranes derived from placental tissue.
Do they work well?
Some of these have shown promise in clinical trials for improving healing rates for certain types of chronic diabetic foot ulcers, particularly when standard care hasn't been successful. However, the evidence can be variable, the cost is often significant, and the choice of which product to use, if any, often depends on the specific wound, the available evidence, and the individual practitioner's experience and preference.
Okay. And we mentioned negative pressure wound therapy again.
Yeah.
Just to reiterate its role.
Yeah, NPWT, the wound VAC. As we noted, it's become a pretty standard tool. It's beneficial in several ways, helps promote the formation of healthy granulation tissue, can significantly reduce the time it takes for a wound to close, and some studies suggest it might even decrease the risk of needing minor amputations down the line. So it's a valuable adjunct to good debridement and offloading.
Sometimes, though, despite all these efforts, wound care, offloading, maybe NPWT surgery becomes unavoidable. What are the situations where urgent surgery is needed?
Right. Urgent surgical intervention is required when you have an infected ulcer that has progressed to form an abscess, a collection of pus, or if there's evidence of gangrene gas in the tissues, which suggests a very aggressive infection, or if the patient has signs of severe systemic infection, like sepsis.
And the goal of that surgery?
In those urgent situations, the primary goals are infection control and tissue preservation. This usually involves incision and drainage of any abscesses and aggressive debridement removal of all infected and non-viable tissue. Sometimes this might necessitate amputation of toes or even parts of the foot right then and there to control the infection or stop gangrene from spreading further up the limb. You have to explore all the tissue layers thoroughly.
And beyond dealing with acute infection, what other kinds of maybe more planned soft tissue surgery might be needed later on?
Good question. After the initial infection is controlled and assuming blood flow is adequate or has been restored, the focus shifts to achieving durable wound closure. Small wounds might heal on their own with good local care or maybe NPWT.
But for larger wounds?
For larger tissue defects, surgeons might employ various techniques. Sometimes local tissue flaps can be used, essentially rearranging nearby skin and soft tissue to cover the defect. The principle is replacing like with like.
Okay.
For more complex or larger wounds, especially over bone or joints, free flaps might be necessary. This involves transplanting tissue skin, muscle, or both, along with its own artery and vein from a distant part of the body, like the thigh or back.
That sounds complex.
It is. It requires microsurgery to connect those tiny blood vessels under a microscope to a blood supply in the foot or ankle. An important technical point is often doing end-to-side anastomosis, connecting the flaps vessels to the side of a main foot artery to maintain blood flow down to the rest of the foot.
And you have to address the underlying cause, too.
Absolutely critical. If there's an underlying bony prominence or deformity that caused the ulcer in the first place, that often needs to be addressed surgically at the same time as the soft tissue closure, or the ulcer is just likely to come back, shaving down bone, correcting deformities.
Which brings us to recurrence. Our sources suggest that's a really significant problem, isn't it?
It's a huge problem. Prevention of recurrence is crucial. Unfortunately, even after an ulcer heals successfully, the risk of getting another one remains very high.
How, huh?
Some studies suggest maybe 35% recurrence within 1 year, climbing to over 75% within 5 years.
Wow. Why so high?
Because the underlying factors, the neuropathy, often the PAD, the foot deformities usually haven't gone away. High pressure on the sole of the foot, the plantar aspect, during walking is a major risk factor, especially for those ulcers on the bottom of the foot.
So what can be done to prevent them coming back?
Well, continued vigilance with protective footwear and orthotics is key. But sometimes surgical procedures aimed specifically at reducing that plantar pressure can be very helpful. Things like lengthening the Achilles tendon, which can reduce forefoot pressure, or performing minor tendon releases like a flexor tenotomy for hammer toes that cause ulcers on the tips or tops of the toes. These can be effective in preventing recurrence in specific situations.
Despite all these interventions, sometimes amputation becomes the only viable option. When does that decision get made?
Amputation, unfortunately, may become necessary when wound closure is simply not possible. This could be due to the sheer size or location of the wound, the severity of tissue destruction, or if there's irreversible ischemia, lack of blood flow that can't be restored sufficiently.
What's the goal then?
The goal is always to remove the minimum amount of tissue necessary to achieve a wound that can heal reliably while preserving as much limb length and function as possible. This might range from amputating just the tip of a toe, a whole toe, a ray amputation, across the metatarsals, transmetatarsal amputation or TMA, or even higher up in the midfoot.
It sounds like the thinking around amputation levels might have evolved.
That's definitely true. With the significant advancements we've seen in revascularization techniques restoring blood flow and sophisticated wound care, a partial foot amputation, like a TMA, is now often achievable and can result in a functional limb, whereas in the past, a major below-knee or even above-knee amputation might have been considered the only option for similar wounds.
So it's not always the worst-case scenario, it sounds like.
Well, it certainly has a major physical and psychological impact, no question, but sometimes, from a purely medical standpoint, an appropriate amputation can lead to faster, more reliable healing, a shorter hospital stay, and potentially a lower risk of recurrent infection compared to prolonged, ultimately unsuccessful attempts at limb salvage. The result can be an acceptable functional outcome.
And after the amputation heals?
The focus immediately shifts back to prevention, ensuring appropriate footwear for the remaining foot, continued patient education, often physical therapy to adapt to the change in biomechanics and optimize function. The risk factors are still there for the remaining limb.
Let's circle back to peripheral arterial disease again for a moment. We highlighted that diabetic PAD often hits those tibial arteries below the knee. How is this managed specifically in the context of these foot ulcers?
Right. As we discussed, it's now very clear that improving blood flow revascularization through either minimally invasive endovascular procedures or traditional open bypass surgery plays a absolutely critical role in limb preservation for diabetic patients who have ischemia contributing to their ulcers.
What are the triggers for treating the PAD?
The main indications for treating arterial disease in diabetics are essentially the same as in non-diabetics. One is lifestyle-limiting claudication, severe leg pain with walking that really impacts their daily life. Two is rest pain in the foot, usually at night, relieved by hanging the foot down. And three, the most relevant to our discussion, is tissue loss, meaning non-healing ulcers or gangrene.
Okay. And what kind of vascular testing is typically done to evaluate the blood flow in these patients?
Any diabetic patient presenting with tissue loss or a non-healing ulcer, especially if they have weak or absent foot pulses, should definitely undergo further vascular assessment.
Starting with?
Often starting with non-invasive tests. As we mentioned, the ABI can be falsely elevated due to calcification. So the toe brachial index, or TBI, which measures pressures in the toes where vessels are less likely to be calcified, is often more accurate and predictive of healing potential. A TBI greater than about 0.6 suggests healing is likely.
What else?
Pulse volume recordings, PVRs, which look at blood flow waveforms, are helpful. And direct measures of tissue oxygenation or perfusion, like transcutaneous oxygen measurement, TCPO2, or skin perfusion pressure, SPP, are very valuable. Generally, a TCPO2 above 40 mmHg or an SDP above 50 mmHg suggests good healing potential, while levels below 20 or 30 respectively suggest healing is unlikely without improving blood flow.
And imaging.
If the non-invasive tests indicate significant PAD, then imaging is needed to map out the blockages and plan treatment. This usually involves CT angiography, CTA, or MR angiography, MRA first. These are often followed by a formal diagnostic arteriogram where contrast dye is injected directly into the arteries under X-ray to get the most detailed roadmap. For patients with kidney issues, CO2 can sometimes be used as a contrast agent instead of iodine-based dye.
Okay, so once you have the roadmap, what are the options for actually improving the blood flow? Endovascular versus surgery.
Both are critically important options. Endovascular interventions working from inside the artery with wires and catheters have become increasingly common as a first-line approach. This includes angioplasty, which is ballooning open the narrowed or blocked artery,
Right.
sometimes using drug-eluting balloons that release medication to prevent re-narrowing. Stents are used less commonly in the tibial arteries compared to larger vessels. There are also specialized techniques for crossing long blockages or reconstructing arteries down into the foot, like the pedal loop technique.
Is it challenging down there?
It can be, yes. Treating long calcified blockages in small tibial arteries endovascularly remains challenging, but outcomes have improved significantly and are often comparable to non-diabetic patients, although the long-term patency, how long the vessel stays open, might be a bit lower. Having at least one patent tibial artery flowing to the foot after the procedure is crucial for success.
And surgical bypass, when is that considered?
Surgical bypass, creating a detour around the blockage using either a vein graft or sometimes a synthetic tube, remains a vital option, especially for patients with extensive tissue loss or long, complex blockages not suitable for endovascular treatment. Probably about 25% of patients with limb-threatening ischemia are best served by an initial bypass.
Why bypass in those cases?
Some evidence suggests that for larger wounds, say greater than 2 centimeters squared, bypass might lead to faster and more complete healing. Because diabetic PIOD often spares the arteries higher up, bypasses can often originate from the popliteal artery behind the knee and target arteries far down in the foot, even the plantar branches on the sole.
What kind of graft is best?
Autogenous vein grafts using the patient's own saphenous vein from the leg are definitely superior to synthetic grafts for bypasses below the knee and lead to better long-term outcomes.
So how do you choose between endovascular and bypass? Is one better?
That's the million-dollar question. The BASIL trial, a large randomized study, compared endovascular first versus surgery first for severe limb ischemia. It found that while surgery had higher initial risks, outcomes at 1 year were similar. Interestingly, patients who survived longer than 2 years actually had better amputation-free survival if they initially had bypass, provided a good vein graft was available.
So maybe surgery is better long-term if you have good vein.
Potentially, but ongoing trials like BEST CLI and BASIL 2 are looking specifically at this question, including more diabetic patients, to give us clearer answers. Right now, the best approach is really individualized, based on the patient's specific pattern of disease, their overall health, the extent of tissue loss, and local expertise. Excellent limb salvage rates can be achieved with both strategies when applied appropriately.
Finally, our sources really emphasize the importance of multidisciplinary limb preservation programs. What exactly are these, and why are they considered so beneficial? It sounds like a team approach is essential.
That's the core insight, yes. Successful limb preservation, especially in complex diabetic foot cases, truly requires a coordinated team effort. It's not something one specialist can typically manage optimally alone.
So what is a multidisciplinary program?
It's a structured approach that brings together all the necessary experts: vascular surgeons, podiatrists, infectious disease specialists, endocrinologists, wound care nurses, orthotists, physical therapists, dietitians, social workers, all working together under established protocols.
What are the advantages of having everyone coordinated like that?
The benefits are really numerous. For patients, it means faster, more streamlined assessment and diagnosis, quicker initiation of appropriate treatment for infections, more efficient coordination between, say, getting blood flow restored and then having the wound surgically closed or managed, timely provision of proper offloading and footwear, and crucially, enhanced follow-up care after procedures to catch problems early.
Leading to better outcomes.
Exactly. Studies have shown these programs lead to improved wound healing rates, lower amputation rates, and better overall patient outcomes.
Any benefits for the doctors or hospitals?
Yes. For providers and institutions, these programs can become centers of excellence, attract referrals, offer leadership and research opportunities, and ultimately demonstrate better quality of care by reducing major amputations.
But are they common? Does everyone get this kind of care?
Unfortunately, access is still a major issue. Estimates suggest that perhaps only about 50% of patients in the U.S. with limb-threatening ischemia actually undergo any attempt at revascularization. Many still proceed directly to amputation without a full evaluation by a limb preservation team. So improving access to these coordinated programs is a critical need.
This has been a really comprehensive deep dive into diabetic foot ulcers. Let's try to summarize some of the key takeaways.
Certainly. I think the main points are that diabetic foot ulcers are a major and unfortunately growing global health problem. They're driven by a complex mix, primarily nerve-damaged neuropathy and poor blood flow PAD, but also infection, foot structure, and other factors play a key role.
And management.
Early diagnosis through a really thorough assessment is absolutely critical. Effective management absolutely requires a multidisciplinary, team-based approach. This has to include meticulous wound care, especially debridement, consistent and effective offloading of pressure, improving blood flow through revascularization whenever necessary, managing infection aggressively, and providing comprehensive patient education and preventive strategies.
All crucial for preventing those devastating outcomes like amputation.
Exactly.
And hopefully, on a personal level, understanding these complexities empowers you, our listener, to be more proactive, whether it's about your own health or the health of people you care about.
Absolutely. Knowledge is power here. And maybe this leads us to a final provocative thought to leave you with.
Good.
We've discussed some really significant advancements in vascular surgery, in wound care technologies, in our understanding of this disease. Yet, despite all this progress, the overall incidence of diabetic foot ulcers and, sadly, major amputations remains stubbornly high, especially within certain socioeconomic groups and ethnic minorities.
So the question is,
What fundamental systemic changes are truly needed beyond the medical treatments themselves? How do we bridge these disparities and ensure that everyone, regardless of their background or location, has equitable access to these limb preservation strategies that we know can work? That's a huge challenge, I think, that requires ongoing attention, innovation, and perhaps a rethinking of how we deliver this care.